in Africa, which was one of our ideas starting off in this project. So what are we talking about? In 2001, Zambia began a large-scale program of malaria control and treatment. There was a very large commitment of domestic resources and donor resources. I'll show you some of the numbers in a bit. The goal was very ambitious, a 75% reduction in malaria incidence and a 20% reduction in under 5 mortality. So why did they do this? Why Zambia, and why did they do it in the early 2000s and not some other time? So there's a long history of malaria control. In the post-World War II period, it was kind of the golden age of malaria control with this magic weapon of DDT. The World Health Organization went around the world controlling or eradicating malaria in very rapid fashion in a lot of countries, India, Sri Lanka, a lot of countries in Latin America. At the time, the WHO viewed Africa as simply too difficult. The mosquitoes were too well entrenched, the infrastructure was too hard. And at some point, the WHO kind of called a truce on malaria, said we've done as much as we can do. And that's where things stood for many decades. Within Zambia itself, there was a very tragic cycle in which post-independence and when the price of copper was high, they did a very good job in controlling malaria. And then there was massive backsliding. The worldwide ban on DDT, institutional difficulties, lower price of copper, and as we discussed in the paper, malaria came back in Zambia. Toward the end of the 1990s, a couple of trends came together. First of all, there was just a maturation of new technologies for fighting malaria, things like treated bed nets and new medications. And secondly, there was a change in donor focus. Aid donors decided they cared a lot about disease. There was the Global Fund for AIDS, TB, and malaria was kind of the marginal case in that global fund, but malaria made it in. And so people in the business kind of got this idea that now was the time for a new assault on malaria. And there was an explicit desire to have a big win, to have a test case where you could show what putting all of these technologies and a lot of money and effort together could do in terms of fighting malaria. And Zambia was chosen as that test case because it was viewed as a country that had the institutional capacity to carry out a successful program. There was political will, and there was a favorable climate. So mosquitoes are not as bad in Zambia as they are if you move further up in sub-Saharan Africa. So that was the background to the initiative. And how did they do? So here's some data I'm going to talk about much more later on, but this is just some raw data on malaria deaths in the HMIS. It's a database in Zambia. And you can see that there's this rapid decline both in under 5 deaths and in over 5 deaths by a factor of something like 50% over this 7 or so year period. These are raw deaths, and this is a period in which population grew by about 30%. So there's a more than 60% reduction in the death rate in this data. So that seems like a big success. That's something to study. In addition to this HMIS data, we have data from the DHS, the Demographic and Health Surveys, in 2001, 2002. The fraction of children under 5 who had fever in the previous 2 weeks fell by more than half, and under 5 mortality fell from 168 per thousand to 119 per thousand. So a difference of 5% in under 5 mortality in a fairly short period of time, which is really a huge improvement. And that's, as I'll discuss later on, that's not all due to malaria control, but it's nonetheless a striking improvement in health. And here are just 2 ways of quantifying the improvement. One, about 25,000 children's lives saved per year. So that's a kind of awesome number. And then perhaps a little frivolously, I thought about making something economic out of this. So in a lot of my work, I'm kind of interested in issues about health and how you do a linkage between health improvements and economic improvements, and that's very hard in terms of utility and stuff like that. But I have a little shortcut, which is to just use the Human Development Index. So the Human Development Index weights income per capita and health according to a formula that's all in our footnotes. And so you can take any improvement in health and translate it into an income equivalent terms. So I don't necessarily endorse the weights that are used in the HDI, but they are something people look at. So if you take the improvement in mortality in Zambia over this period, it's something like 25% growth of GDP per capita. So that's a big number. So what are we going to do in this paper? Well, a lot of this paper is really about kind of exploring the data and exploring what you can learn from the available sources. So I say here we apply our skills. So we're not epidemiologists, we're not public health people, we're quantitatively oriented economists. And there's a lot of stuff we don't know and a lot of things that we should be humble about. But we do have some skills in terms of data analysis and stuff like that. And so we want to take those skills and apply it to the data to see if we can help in this process of understanding what's going on in this big health improvement. And that's really what most of the effort in this paper is about, just sort of understanding what's going on. Part of that is understanding the relationship of inputs to health improvements with outcomes. So we want to, sort of ideally assist in learning what works well. Where do you get the biggest bang for buck in the different treatment modalities that are being rolled out? As I say, we need a lot of caution in doing this because there are a lot of econometric problems in using the available data to infer what works and what doesn't work. And again, we're sort of treading in the territory of real doctors, and we don't want to kind of look at the data and jump to some conclusion that we know better than them. And then finally, what we like to do as part of the larger project, but it's not in today's paper, is use the Zambian initiative or experiment to understand more about the economics of disease and the economics of malaria in particular. So we want to learn about the economic effects of health improvements. Okay. So what data do we have? Well, one thing we have is this very standard demographic and health survey, nicely cut up for us already by the folks who collect these things. It's actually very good luck that there's a DHS in 2001 before the initiative and a DHS in 2007 after it's mostly gotten going. So that's going to make our work a lot easier. Secondly, we have data from the Zambian National Malaria Control Commission on spraying, bed net distribution of antimalarials, rapid diagnostic testing, and all the commodities they put out there. And again, there's some good luck here because the NMCC in Zambia takes an extremely strong hand in coordinating the distribution of health inputs. And in some countries, that's not the case, and kind of everyone's distributing what they feel like where they feel like it. And in Zambia, they really centralize everything and they collect data as it goes out. And then finally, we're going to use this thing, the Health Management Information System, which we've spent a lot of time about, so I feel quite close to it. So let me tell you about my new friend. So the HMIS was started in 1995. In 2009, in January in 2009, a new system was introduced. So we're dealing solely with the old HMIS that runs through 2008. Data is collected quarterly. There's data on inpatients and outpatients by disease diagnosis. You get outcomes like deaths. There's also parallel information on service delivery, nets, and spraying, and so on. The data comes from all Ministry of Health facilities, so these range from big hospitals in Lusaka to big hospitals, except for these very special referral hospitals in Lusaka that are not in the data set. So from hospitals to little health posts that would be staffed by a single community health worker. It's a kind of pyramid structure, so data is passed from the facility, where there are log sheets and kept, up to the district level, and then it's passed on to the province level, and then it's passed on to Lusaka. The data is cleaned and checked at the district level, and then again at the province level. And so when we read about this, we're like, okay, this is going to be great. We can really learn a lot from this. And then we started learning about all the different opportunities for error that there are in collecting this data. So first, just at the facility level, there's enormous heterogeneity in the quality of record keeping. Sometimes it's done, by very responsible people as the patients come in. Sometimes it's based on end-of-the-month recall and kind of guesses, or it's filled in by people who are semi-literate. There are problems with data entry. Data was entered once. There were no consistency checks, no screens, no nothing. It just kind of got in there. And then what turned out to be a huge problem was when the data got to Lusaka, only the most recent quarter would be appended to this national data set. Meanwhile, any late reports or any corrections that happened at the province or district level would update those data sets, but not the central data set in Lusaka. So these things just completely didn't match each other, and it was extremely frustrating. So what we did was we got money to go out and try and fix all this. So that involved recollecting data that never made it into the data set. A lot of what we did was sort of apply statistical tools to the version of the HMIS that they gave us, scanning for duplicate figures, scanning for huge outliers, doing kind of quarterly adjustments and all sorts of fun things like that. And then going back to district health officials to find missing reports and to justify irregular data and say, is this really the number that's supposed to be here? Can you go back to the facility? Can you find out why this number is so different from that number? The kind of thing that might have been done at the time of input if they had a really good system. And part of doing this, we ran these provincial data workshops where we brought in people from the facilities and the district level health data officers and things like that. Went over data analysis. This was not just about improving data. I don't want to give the wrong impression that we spent $200,000 just making the HMIS better for this paper. There was definitely a capacity building dimension to this, teaching the local officers to kind of get a better handle on their data. And we hope, in the process, improving the quality of this HMIS. So we filled in missing observations. You can see a whole table in the paper of the number of corrections we made. And just to sort of show you the most striking example, in the original HMIS as we got it, if you looked at under 5 malaria deaths, they rose by 13% between 2006 and 2007. It's kind of a bad thing to be happening in the middle of a massive anti-malaria campaign. It turned out that there were 3 districts that just had completely screwy reports for 2007. You could kind of just see them as massive outliers. Went back, found the right data, corrected it, and you find that malaria went down. Okay. There's still a lot of issues remaining to be concerned about with the HMIS. I'll just go over some of them briefly. One is misdiagnosis. This is very common in sub-Saharan Africa. There was a tendency to treat a lot of fevers as malaria, whether there was a diagnosis or not. Over the period that we're looking at, these rapid diagnosis test kits, these kind of molecular biology things that a not very well-trained person can use to diagnose malaria in 20 minutes, were introduced, and guidelines were introduced that you can't prescribe the ACT therapies without first having done a diagnostic test. And so that's going to make malaria diagnoses go down a lot and maybe bias the trend in what we see. There's also stigma associated with HIV, so a lot of HIV deaths we fear are being reported as malaria. And then there was this abolition of user fees in rural facilities. You'll see in some of the data later on. There's a big spike in outpatient visits. One of the things we do to try to minimize these biases is just look at serious cases. So we look at deaths, and we look at particular under 5 deaths. And when we look at inpatient cases, we think we're more likely to be getting correct diagnoses, because if someone is actually in a facility long enough, they're going to be seen by a clinician repeatedly. Maybe their blood will be looked at under a microscope, and so we're more likely to get a correct diagnosis. A second issue, and I think this is kind of the most troubling thing about the whole paper, is that not all cases or even all deaths make it into the HMIS. And the worry might be that it's a non-representative set of cases, and this is going to bias our ability to look at trends in health over time. So you might think that the HMIS is going to do better in cities than in the countryside because people are closer to facilities, so we might miss a lot of malaria mortality. And also we think that a lot of these interventions were rolled out in the same places where there are facilities that appear in the HMIS, so we might be biasing the magnitude of the effects from the malaria rollout. So here's, again, this is the place I'm least happy with our data. So here's just an attempt to assess what fraction of deaths of under 5 children actually make it into the HMIS. So in the first column you see deaths that we record per 1,000 children under age 5. This is from the HMIS in 2001 and 2007. So you can see there's this 41% drop. We're going to want to compare that to under 5 mortality, calculated in a sort of demographic fashion in the DHS. The right way to do that is not just to multiply by 5, but it's a sort of rough and ready approximation. So that's what you see in the second column. And then in the third column is the data I mentioned on DHS under 5 deaths. So the bad news here is it looks like we're getting between 1/4 and 1/5 of these under 5 deaths. So we're really getting a fairly small fraction. So that's going to make us worried. The other thing is when you look at the change over this 6-year period, there's a much larger decline, 41% in the HMIS relative to the DHS. Actually, that turns out to not be so worrisome, because if you think about the way the DHS calculates under 5 mortality, it's a survey done in 2007. They ask about all children born over the past 5 years and the ages at which they died, if they died, and then do a life table based on that. This was a period in which mortality from malaria was falling very rapidly. So the number you get in the DHS is some kind of weighted average of the period 2003 to 2007, whereas what you get in the HMIS is just the data for 2007. And as you can see here, if you recalculate the HMIS change in under 5 deaths, taking the average of 2003 to 2007, you get 29% decline. So it exactly matches the DHS. So that's some good news for us. Oh, come on, give me 15. All right, so here's just a little more comparison. This is the number of deaths by province in the DHS and the HMIS. And there's this huge outlier of Lusaka. The HMIS records far too few deaths in Lusaka. We actually solved that problem. It turns out that there's a referral hospital in Lusaka. It's not in the HMIS because everyone who goes to that hospital has to be referred from somewhere else, and the data is supposed to be flowed back to the place that referred them. We're pretty confident this is just an issue of the data not being flowed back to the places that referred them. Here's the change in mortality by province. It looks somewhat better. I'm going to skip over this finally. There may be a lot of non-reporting facilities, so we create a sample of always reporting facilities, what we call the high-quality sample. That looks a lot like the regular HMIS data, except in 2008. You can read about the paper for the problems in 2008. And here in NBER, tradition is a chained index comparing adjacent years for facilities that always report, and that tells a fairly similar story. And finally, just in case you were worried that the whole decline in malaria that we're seeing was just that the HMIS was capturing fewer and fewer deaths over time, here's the ratio of malaria deaths to non-malaria deaths. And you can see that this falls significantly over this period as well. So clearly there is a big reduction in malaria mortality going on here. One thing that we can do with the HMIS that you can't do with other data, so we're very interested to see what this looks like, is since it's quarterly data, and this is the NBER, after all, you have to run a regression with season dummies or quarter dummies. And so this is what you get when you look at the full data set. So red is malaria deaths, and blue is all under 5 deaths. The first quarter is the quarter of high malaria mortality. That's the rainy quarter. And so every other quarter has a negative, and that's the reference group in this regression. So every other quarter has a negative dummy. And you can see about half of the seasonal in mortality is driven by malaria. We then take the sample and we divide it into just 2 halves, which we call pre and post. So really this is kind of a continuous rollout of an anti-malaria initiative. But you can see that the seasonal and malaria mortality declines by about half over this period. So this is kind of a good check that we're really getting malaria mortality, because this is what the seasonal for malaria mortality is supposed to look like. And then here's the decline in the seasonal for all-cause mortality. So that's largely, although not entirely, driven by the decline in the seasonal for malaria mortality. So that's kind of a neat thing that you can do with this data that you can't do with other data as a test. All right, so very briefly, the elements of the program were kind of, if you read about health in Africa, you know all these things. It's treated bed nets. In 2008, more than half the budget of the Malaria Control Commission was designated for bed nets, indoor spraying, ACT therapy, rapid diagnostic testing, and treatment of pregnant women. It's very important, as you saw in this previous data, to note that stuff was going on besides the malaria initiative. So there were big initiatives in HIV, TB, and child health generally. So not by any means all this decline in malaria, in mortality, is due to malaria, and that's going to make sorting things out somewhat more difficult. Here's just the data on the rollout. In the initial design of the program, spraying was going to be restricted to urban areas where it was viewed as cost efficient. The thrust was on bed nets. You can see that there's this ramping up of bed net distribution, though definitely not monotonic. So you get a big decline in bed net distribution in 2004. As far as we understand, that has to do with problems in supply of nets from donors. You then get this very rapid ramp up through 2007. In 2008, the planning documents and the budget called for 3.5 million nets to be distributed. And again, problems with supplies from donors led to less than 1 million nets being distributed. And at the same time, there was a reorientation of the program towards spraying. And we don't fully understand what happened here, whether this was kind of based on analysis of data from the field or what they got from the donors. But there was this shift from primarily focusing on nets and doing spraying only in a few select districts to expanding the number of districts where spraying was done, so that by 2008, half of the districts were being targeted by spraying. And if you look in the paper, I didn't put it in the slideshow, there's a nice little graphic showing you districts covered by spraying over time. This is just a table looking at net distribution according to the DHS, and net distribution according to the NMCC, and net usage according to the DHS, and there's a relatively good correlation between the two of those. And here's the same thing for spraying. So there's, we're basically just checking that the places that the NMCC thought they were deploying nets and spraying are indeed the places where people report that they're using nets or being in sprayed structures. All right. So the last thing we want to talk about is this assessment of the role of the link between inputs, nets, spraying, and so on, and outcomes like death and disease. And so the natural thing to do is run some regression of outcomes on changes in these inputs. And of course, this is very dangerous territory because these inputs are not randomly applied. And so it's going to be very difficult to get a structural estimate of the effect of applying one or another modality treatment on outcomes. Right? So what are the problems? So resources are pushed to areas that are in need, where malaria is high, or where malaria is forecast to be high. What is pushed where is chosen at least somewhat in an optimizing fashion. So there are people in Lusaka thinking about what would be best in what places. Those are kind of two obvious things. The third thing is something we really learned from our field work, which is that the efficacy of the local staff is hugely important. So there are just enormous differences. We can't quantify these, but they appeared, they were apparent to us in the quality of the local health staff by district. So some places you have district health officers who really have their act together. They're getting their inputs out to all the people who need them. People are being tested properly before they're given ACTs. And by the way, good records are being kept. And in other places you have the opposite of that. So there's kind of huge variance in that. And that's going to be an extremely important omitted variable in determining what happens to health inputs over time. So we can assign these biases some. So if inputs are pushed to places that have bad current conditions, so if high malaria in a district triggers more nets or more spraying, of course everything we do is going to have district fixed effects, but if we think that there's kind of some time variation in this, then temporarily high malaria is going to trigger a lot of inputs in an area, and then malaria is going to come down. Possibly it would have come down anyway. So that's going to bias upward our estimate of the efficacy of these treatments. Kind of the same thing's true for this health staff efficacy. So places that have good health staff also get better inputs, and so that's going to make it look like the inputs are working. And then this kind of forecast conditions goes the other way. If you think that really people can forecast where malaria is going to be bad and push the inputs there, then that's going to bias downward the estimate of the efficacy of inputs. So do we have any identifying variation whatsoever? Thanks. I think we do. I mean, we have identifying variation to the extent that there's a deviation of what was actually done from some optimal plan. And luckily this is Africa, where all sorts of unexpected things happen in terms of the distribution of inputs. So we think there's a lot of those. And then there are all sorts of discontinuous responses. So for example, in this rollout of indoor residual spraying, the number of districts that were targeted was kind of changed in a discrete fashion from year to year. And districts were either targeted or not targeted. There were also stockouts of ACTs over the course of this period, and apparently of bed nets in 2008. So things like this are giving us more identifying variation. So it's kind of, the more random is the treatment, the more likely we are to estimate what it's doing. Okay. So what we're going to do is basically look at the link between inputs as we get them from the NMCC and outputs, and we're going to do that both in the DHS, and we're going to do this in this HMIS data. So here's DHS data. We're looking at regressions of child fever over the last 2 weeks. I'm not going to talk about the first columns because they're not identified. So in the third column, we're regressing on bed net distribution per capita. There's a full set of year dummies here and of district dummies, and we're controlling for all sorts of household demographics. And you can see that you get the coefficient you're supposed to get, which is distributing more bed nets. And here, bed net distribution is over the period between the two DHSs, so it's cumulative over that period, reduces fever. In the last column, we actually instrument for whether the household owns a bed net with bed net distribution per capita in the district, and you get a negative and significant coefficient, perhaps larger than it should be. I don't show it here, but we do a placebo test with diarrhea over the last 2 weeks. It's another important health consideration, but it's not affected by bed nets, and it gets a 0 coefficient. So that's good news for us. One of the things we worried about, as I mentioned before, is that sort of things are being pushed to places that have high malaria prevalence. So we just control for previous malaria prevalence, and that actually reduces the coefficient on bed net distribution, though it still remains significant. And here we do the same thing with child death over the last 5 years, and once again, you get a negative and significant coefficient. So what that coefficient says is that full coverage by bed nets in a region, in a district, would reduce child deaths by 4.4 percentage points. That's about 1/3 of the child mortality, so it's a significant amount. Now we're looking at the HMIS, where we have this data on a much finer time scale, so we can compare it to year-by-year rollout of bed nets. So we're looking at regressions of malaria outcomes on nets per capita in the current year, one lag of nets per capita, which is what we expect to be the most significant input, because these nets are distributed generally before the rainy season. The rainy season's at the beginning of the year, and 2 lags. And you get basically what you would hope to get, which is that you get this reduction in malaria inpatients and deaths and so on from net distribution. Coefficient that we're not so happy with is this coefficient on other deaths of children under 5. So you might think that this was some kind of comorbidity or that there's something wrong with our estimate there. We do the same thing with spraying, and for both the DHS and the HMIS, we get somewhat weaker results. So when we just do a regression of child fever in the last 2 weeks on the percentage of the district population sprayed, you get a positive coefficient. That is the opposite of what you would expect to get, and the same if you look at the household sprayed in the self-report. When we restrict the sample just to looking at the second wave of the DHS, we just get insignificant estimates. And in the HMIS, we get somewhat more of the expected effect of spraying. So when you include both a dummy for whether a district was a target in spraying in the previous year, because the spraying is done late in the year before the rainy season, and one lag of bed nets, the coefficient on bed nets comes in roughly the same as it had before, and the coefficient on spraying comes in negative and significant. And if you look, say, in column 5, comparing the coefficient on spraying being, this is now a dummy for whether your district was targeted. Having your district targeted for spraying has about the same effect on mortality as distributing 100,000 bed nets. So that's sort of the beginning of a cost-benefit calculation that one could think about doing. When we do all that adjusted for population size, so we look at the fraction of households sprayed rather than a dummy for whether the district was targeted for spraying, and we look at nets per capita, the nets per capita remain significant, and the fraction sprayed now becomes insignificant, although the coefficient is not, it's not that far from significance. And finally, I'm not going to talk about that map. All right, so let me talk about 3 different sets of conclusions. So first, just regarding the campaign itself, it's been a huge success. So the international community and the Zambian government set out to make a big dent in malaria mortality in Zambia, and they succeeded. So that's the first thing to say. At the same time, there were huge successes in other dimensions of health as well that had nothing to do with the malaria program. And from our own point of view, this cleaned up HMIS, sort of this new data source that we put all this effort into, turns out to be a pretty useful tool for tracking the impact, tracking the rollout of these anti-malarial programs and looking at their impact. To the extent that we can say something about this mapping from inputs to better health to outcomes, we have very, very, very tentative evidence that we see nets working, and we don't see as strong evidence of spraying working. But I don't want to push that because, as I say, that there's real doctors out there who work on that. In terms of directions for future research, but this is the part about your work.
Oh, well, take your time.
Okay. So, what got me into this was the question of the economic effects of malaria or of health more generally. So we have this literature by MacArthur and Sachs and various papers like that that show that there's this huge effect of health on economic outcomes. And we know there are a lot of problems with that. We know that there's kind of this huge omitted variable bias, that things that might have a positive impact on health would also have a positive impact on economic outcomes, or there's endogeneity of health improvements. We have this brilliant paper by Asimoglu and Johnson that takes an IV approach and looks at changes in health technology in the mortality transition after World War II to instrument for changes in health. And the first stage is very successful, and the second stage basically shows zero. So they show that improvements in health have no effect on economic outcomes. And then we have my own work with a different Ashraf, not Nava, that kind of takes a more micro-based approach, trying to estimate the effect of health improvements on economic outcomes. So those are all fine. Well, both Simon and my papers are fine papers in this literature, but they're not convincing to everybody. And it seems like Zambia is a really great case for studying the economic effects of health improvements because it provides good identifying variation. Most importantly, you get this largely exogenous increase in health. So the world community decides that now is the time to make big progress in health in Zambia, and they do so. Then you get of course, that just, at the national level, that's just one data point, so that's somewhat problematic. You get these big regional variations in the rollout, and there's some randomness to that, and we think it's possible to identify other shocks. So some of the things we want to look at, kind of the natural suspects. Demographers and economists have written a lot about the effect of health improvements and mortality reductions on fertility. So sort of your standard model is that when mortality falls, net reproductive rate goes up, and then eventually fertility falls, perhaps in a more than compensating fashion. Malaria is an unusual disease in this respect because malaria has big effects on fecundity, especially for first births. So it's something we want to study more. Just looking at what we have in the DHS, in fact, rural total fertility rose over the period 2001 to 2007, which is when this big malaria eradication was going on. So there's certainly something interesting going on there. We want to look at labor productivity, and we're actually working with a company in Zambia to get data on how hard workers can work when they do a big eradication. And we want to get data on, we have data on education as well. That's sort of a natural place to look at the economic effects of disease control. So that's all for future work. Finally, I think it's important to kind of remind ourselves, this is mostly not about economics. This is mostly about health improvements. So what else can we say? Well, Zambia didn't set out to eradicate malaria. So this is not the Sri Lanka model where you go, you spray every household, you get parasitemia in people's blood down to almost zero, and at that point you can really kind of pull back on your control efforts and keep malaria at a very low rate. So the old model, the post-World War II model, was you do a big push against malaria, and then you kind of do monitoring and control. Well, you can't do that if you're only doing a 3/4 reduction. So Zambia is still full of vectors, and Zambia is still full of infected people who harbor the parasitemia. And that means that maintaining that low rate is much harder than it would be if you got rid of the thing. So kind of this big push model is not right, and in fact, the resource demands in maintaining low malaria mortality are going to remain high for the foreseeable future. And we all know kind of the history of Africa in terms of health and in terms of other economic things as well is one, as Bill Easterly would tell us, of kind of high hopes and big accomplishments and then huge backsliding. And there is that danger. There's no reason to think that's happening in Zambia now. They're doing a fantastic job, but that's a depressing thought to end on. Thanks.